Hey, what's up, everyone? Welcome back to Basically EMS, the EMS podcast for everyone. Got Wade and Kylee today, and we are going to be talking about diabetes mellitus. The old diabetes mellitus.
The sugars.
The sugars.
Yeah, the sugars.
Yeah, I got the sugars.
Diabetes.
For those of you that don't know, if a patient tells you, especially an old Southern patient tells you, I got the sugars, it means that they've got diabetes. So
I didn't think Wade and I had the same cardiology instructor, and I just thought it was a him thing because he's a very quirky man. And then I actually heard a patient say it. Like, I got the sugars, and I was like, oh,
yeah,
people really say that.
I think it's kind of a regional thing, but it definitely is a thing for sure.
It's like have a Coke, but different. We'll move on.
Soda pop.
It's going to be like everybody says that.
Well, like, you know how, like,
soda pop.
yeah, down south, they instead of say soda or pop, they say, I want a Coke. And a Coke could be
yeah.
anything,
Okay,
right?
yeah, I'm picking up.
Regional diction, that's where I'm going.
Picking it up now.
Yeah.
Cool. We're really starting this one strong.
I mean, sugar.
Speaking of diabetes,
Yeah.
Coca-Cola.
Yeah.
Yeah.
There you go, right
Yeah.
there.
Beautiful.
So as always, let's kind of go back and talk a little bit about the basics of kind of the physiology for diabetes. So obviously, glucose metabolism is kind of where we need to start, right? So our brain is going to need glucose, and that's just a sugar in our body that our cells use for fuel, right? We need that. We need that glucose to break down so that we have fuel. We can create ATP, all that stuff, right? So we need that everywhere, including our brain, which is really where we're going to see those changes, at least the more significant changes in a diabetic patient.
Isn't it like, is it 60% of the sugar you take in goes to your brain? It's like 60 or 80% or some crazy number like that. It's the majority of it.
I'm not sure on the top of my head on that one,
Yeah.
but a good amount.
It's the majority of it.
Glucose is a simple sugar anyway, so like whatever we break down is going to convert. But yeah, you're on the right track. Like, especially with the brain, remember the brain can't use alternative fuels, right? Sugar is what it is. The rest of the body will get into, ketone production and that kind of stuff, but the brain itself doesn't have a choice. Yeah. That's what it needs.
Yeah. And so for that glucose, and I know you were saying you have kind of a good thing for this too.
I mean, we'll tie it in a little bit more to type 2 with this, but glucose cannot enter the cell without insulin. And the way that the book has us describe it, I think does a really good job. So think of insulin as the key, right? So the cell is the gate, insulin is the key. Without the key, sugar will not enter the cell. So by extension, right, if someone's a type 1 diabetic and they don't produce insulin, which we'll talk about here in a minute, that's going to be a make or break, right? Because if they don't produce the insulin, they're going to have that sugar buildup. If they keep eating, inversely, if they have any sugar residual by the time they take their insulin, that could pull all of the sugar, and then that enters the hypoglycemia. So we'll kind of see a different example when it comes to type 2, when it comes to that key kind of method. But just remember that if we don't have insulin, sugar is not really usable.
Yeah, and the normal body and somebody that doesn't have diabetes or anything can manage that, produce the correct amount of insulin based off the blood sugar to get that where it needs to go without pulling too much out and making hypoglycemia or leaving too much. And, and so it is a function of the pancreas to create this insulin. Normally it's when people start to have issues with it that the body can't manage those things. So,
right.
Like I said, insulin is going to be produced in the pancreas by the beta cells and the
Islet of Langerhans.
It's such a fun thing to say.
Yeah.
So that's going to be the beta cells in there, not to be confused with beta cells like for the
beta 1, beta 2.
Yeah, like
receptors, not the beta receptor.
Yeah, exactly. We're talking about that's the neurosystem. That's a different thing. We're talking something different here. And then the pancreas will also create glucagon in the alpha cells. We don't talk about that too much at the basic EMT level glucagon, but we do have stores of glycogen in our muscles, in our liver, throughout our body. And so glucagon is going to be used to break down those additional stores if there is not enough free-floating blood sugars, right? So good to know if you want to move on to higher levels. Advanced EMTs and paramedics typically, and again, this could be local protocol dependent, but can give glucagon IM. So we
I
carry
know
it.
some systems allow, EMTs to assist with like the glucagon pens. That
cool.
people have at home. Some systems do, but it's kind of like what we teach EMT basics. Like it's the assisted administration.
I didn't even realize there were glucagon pens. That's a interesting thing.
It's kind of like, I mean, I only encountered a couple of those that actually got used, but it's kind of like, your rescue meds for like seizures and stuff. They're used, I'd say, way less in that case, but some people have them. They're expensive.
Interesting.
Naturally.
Yeah, as is everything.
Anything with diabetes.
Yeah. So you might have the ability to give glucagon. So know, again, local protocols. And if it goes beyond the National Registry kind of scope, you should be trained on it. But it's a good idea to understand the glucagon breaks down those glycogen stores that we store in our muscles.
And I like to describe glycogen as just like long glucose change. Just think of it as like extended saved glucose. You've saved it so long that now it's sticking together like sugar does, right? That's how I kind of rationalized it. But yeah, whatever your scope says, whatever your protocols say, maybe pay attention to it.
Glycogen is the stored form of glucose. And I think that's what a lot of people struggle with.
Yeah.
Your liver just converts it back and forth.
Typically it's free floating in the bloodstream. It's a little bit different here.
Yep.
So pretty basic physiology for this stuff. Coming down to actual diabetes, it's pretty straightforward. It is for certain different reasons, which we'll get into more specifically, but it's the body's inability to produce or use insulin to allow those sugars to enter into the cells, right? That's the basics of diabetes. And so the brain's going to be starved, the body's going to be starved of fuel because it's not able to get that fuel for one of two, I guess not necessarily one of two different reasons, but
I mean, the big two we'll talk about.
Yeah.
Big two, and then that's kind of going to be it. So let's jump into type 1 first. And so type 1, you might hear type 1, you might hear childhood onset diabetes.
Oh, yeah.
That might be a term you might hear. Or insulin dependent diabetes is also another term you might hear kind of interchangeably here.
Or DM1, diabetes mellitus 1.
Diabetes mellitus. For those that have the sugars. And this I feel like is a fairly recent discovery. I think this is kind of considered an established fact that diabetes 1 is an autoimmune disorder. I know, like when I went through EMT school, they weren't really sure what caused it.
Same. That's what I heard. They're like, we don't really know, but now we know it's 99% of the time type 1s are autoimmune.
Which also checks out for autoimmune because they're hard to find anyway.
Yeah.
So essentially, the immune system is going to attack those pancreatic beta cells, so it can't produce insulin anymore, right? So type 1 is going to be lack of insulin. They're going to be insulin deficient. They're not able to produce insulin. Usually going to happen during childhood, but could be up to in their 40s.
Yeah, it says up to the 4th decade of life is the verbiage the textbook uses, which I think that would suck. Could you imagine being like 40?
He was 36. He was 36 and he got his type 1.
You got a childhood disease. Sorry.
Yeah, well, and which we're going to talk about it, like the 3 Ps of diabetes. He had exactly that. And I talked to him and I was like, you should probably go to the doctor. He's like, I'm getting older and my body's just not working as well. And I was like,
30s is not.
Well, and I was like, everyone acts like their 30s are the new 50s. But I was like, you shouldn't be feeling like this all the time. And he got his type 1 and he went pretty much straight on to insulin.
Yeah.
And it happened fast.
Yeah. I had a family member that had gestational diabetes and was told like it's gestational diabetes, whatever. And kind of was managing it during pregnancy, which gestational diabetes is diabetes that affects pregnant women. Generally, it just self-resolves and it goes away after. So that was what they thought was the case until this family member was found unconscious by the rest of the family and was in a coma for like 2 weeks and has been on insulin since. And she was in probably her 40s.
Wow.
Maybe like mid to late 40s. When she got the diagnosis.
For a female? Interesting.
It's type 1? Is that,
it's insulin dependent. So
I can make the argument.
I don't know. Now there's been, she's changed lifestyles a lot. Sure. And now that there's been some talk like maybe you weren't actually type 1, maybe it was like type 2 thing. But either way, there was no diagnosis until after this happened and went to the hospital like GCS3 unconscious, like for real DKA, sugars off the charts, kept in a coma for like 2 weeks to recover, and it was bad.
Therapeutically induced coma.
Yeah. But yeah, so it can happen later in life. So that's why this is so important for us to be able to recognize the, not just like the signs of hyperglycemia, hypoglycemia, but kind of new onset diabetes. I know for sure I've at least had one kiddo that I took in and I went to the nurse like, everything is matching up for diabetes. They don't have a diagnosis, but everything is making sense and their blood sugar is really high. So this is what I think is going on.
I had an inverse with that one. I discovered type 1 diabetes in a 3-year-old because of low. And it was difficult because all we were going off, because, kids can't talk. So we're going, mom and dad are saying the kid's lethargic, not acting right. It's like, well, let's start where we always start. Let's get a round of vitals and let's check a BG. Sure enough, BG was like 50. So kid's alert, looking around. I wouldn't say oriented, but once again, 3-year-old orientation, right? So
if they're not screaming, they're altered.
Right. And so it was one of those where it's like, well, I could try oral glucose, but the kid's probably not going to like it.
Yeah.
I was fortunate enough, though, that mom's like, I have sippy cups. I'm like, do you have juice? And then we were able to get her to drink juice the entire way. And so I believe her sugar the first time was like 56, 50. I was able to get it to like 87. And it was just maintaining that juice drinking. And we were like far west side before going downtown. So it was a trek. The biggest thing for me is I felt really bad with that kid because I poked her like 6 times, just checking that sugar because I wanted to make sure that juice was helping. It just didn't feel reliable enough. So I poked her more than I had to. But I was just trying to do my due diligence. And then pro tip on kids, poke their heels, not their fingers, more surface area.
Yes.
Yeah, little tiny fingers. We don't want to deal with that. We want to go with the heel pokes.
Right.
So yeah, and I think Kylee was saying the 3 Ps earlier, right? So, what are the 3 Ps, Kylee? Hit us with them.
Polyuria, polydipsia, and polyphagia.
Which are?
Excessive urination, excessive thirst, and excessive hunger.
Yeah. So
which makes each of them makes perfect sense.
Yeah, if you think about it, they are really hungry because their body's starved of fuel. They have really high levels of sugar in their body, and so they're peeing that sugar out, and so they become really thirsty because they're excessively peeing. So polyuria, polydipsia, polyphagia. Yeah, it makes perfect sense when you know.
Yeah.
And then that polydipsia, another thing I was reading is that sugars in our body is a macromolecule. So it's big. So it has its own like gravitational pull, right? But it pulls water. So that's another reason they start getting thirsty, right? Because they're urinating and pulling excess fluid from the body, which is just another example of systemic dehydration.
Yeah, which we'll talk a little bit more about with HH&S when we're talking about type 2. And then weight loss and fatigue can also be pretty common ones, which again make perfect sense, right? Like they're not able to put on weight because all the sugar, all the fuel is just being peed right out. And then they're tired because they have no fuel, right? It all kind of makes sense for the new onset. So,
And I know sometimes they describe anorexia in here, and it's like 4 symptoms, especially with like your endocrine patients. So like, because your appetite is, a huge reflection of your metabolism. So you might see anorexia, which is not the anorexia nervosa, the psychological condition. This is just the symptom of anorexia.
yeah.
And I think a lot of people don't know that's the actual word for it. When you have like decreased appetite and things like that, that's actually anorexia. That's what we call it. And you might see it with these guys if they get super sick. Once they start reaching that DKA stage, they'll be anorexic, but they still aren't producing what they need.
That like skinny failure to thrive kind of look.
Exactly. Yep.
So these patients typically are going to be taking insulin. If they're not new onset, if they've been diagnosed, they'll typically be taking insulin. Maybe they will be taking some oral medication as well, but they should be on insulin. There's different types of insulin that we don't need to go into here. Just as long as you know that they're on insulin, that's what's really important, and try to get an idea of when they last took it. But there's long-acting insulin, there's short-acting insulin, there's all sorts of different insulins that they could take. They may take both. They may do like a long-acting in the morning, and then based off their blood sugar ranges, they'll take like a shorter acting after a meal or before a meal, and they'll calculate it out. So
They've got it down to a science.
What's that?
A lot of them have it down to like a science. Like it's crazy when you talk to them. They'll be like, "Oh, I had this meal. I'm going to do this many units." Compared to if I would have done this meal and they added like one thing to it. It's crazy.
Yeah, there'll be a lot of the time. The ones that are really good about managing it will know carb counts, and they'll just do calculations off carb counts and all that stuff.
Right.
But which is not everybody. Which we don't see those patients, right? That's the thing. I had a guy that was in his 60s, I think, childhood onset. First time he'd ever had a 911 called. He showed us he had logbooks. He would get up in the middle of the night and check his sugars. And if he had to eat some crackers or something, he would.
Yeah.
And I don't remember what the situation. It was something weird happened. I don't remember what it was that caused him to miss like a meal he would normally have eaten. But I mean, he'd been doing it for like 60 years and had never
very successful.
Yeah, really on top of it. So
I mean, I've ran the call, I'm sure you guys have too, of someone taking the wrong one too.
Yeah.
Like, oh, I took too much of my fast acting and I'm supposed to take my long acting right now, or vice versa. And a lot of it is just, well, it's management at this point, you know, like you're gonna have to stay awake and watch yourself a little bit and have someone with you.
Yeah.
If they don't go to the hospital.
I saw more and more pump failures too, like in the last few years. Not saying anything against the pumps, but I think the people who've got them, like the ones that have had them for a while, they're probably just like, it's almost like a generational thing. You know, like the pumps are just starting to get old.
Yeah, it's time to get a new pump.
Yeah. But they, like when I started in EMS, like, you know, well, however many years ago, you know, like pumps weren't as big of a thing, at least not that I saw. And now like everyone has them.
They have that little deal that I describe it. It looks like an air tag on the back of their
It's called a
arm.
continuous glucose monitor, or CGM.
I like air tag better.
Well, that's what it looks like a lot of the time. Yeah, those go, I believe, transdermal.
Yeah,
No, they're not transdermal. They're like subdermal.
They've got these little like prong.
Really short little like needles that go in. So there's not actually pulling sugar like the bloodstream blood. It's I don't know. I looked into it a
Ambient
while
tissue
ago.
blood almost.
It's not the blood that it's actually pulling from. I don't remember where it's pulling from. I mean, you know, if you're watching this, listening to this, you can look it up if you're interested.
Yeah.
But they're able to get a blood sugar reading off of those. And a lot of them are pretty slick. They just have like a phone app that they just put their phone to it and it'll pull up their numbers.
And it shows you the history,
Yeah, which is really nice.
which is super nice.
I went on a call once for a college student at BSU, and her boyfriend typically lived out of state, but he was just happened to be there for this situation. But it was set up so if it dropped below like 50, it would contact him. So he was here.
Yeah, those
but
are cool.
I think she was in like a different room or something, or like he went to take a shower, something like that. Like they were separated for a little while, even though they were in the same house. And he got the alert, so he called 911, and she was super low. And that was that CGM was set to trigger that way. So they're pretty cool, and they can interact with insulin pumps too.
Yes. Yeah,
which is
because
nice.
I think that's the one I heard when the Dexcom. I think that's what it's called. I think that's what I was trying to think of. But it talks to their pump and then just like creates its own like treatment thing for them. It's crazy.
Yeah. Yeah. So some patients will have insulin pumps. And so those are usually on like the hip. Commonly is where you'll see those.
Got
They
that
might wear them
little
on their
port,
Yeah.
like, or whatever.
Yeah.
I have a story on one of those.
Yeah, go
so it's a Wade looks stupid story. There's a few of them
best
out there.
kind.
Yeah.
The humbling ones.
I was in medic school, and one of my classmates, you guys know her, one of my classmates had a pump, and I didn't know. I was so green when I started paramedic school. I didn't know what it was. And so I swear she pulled it out, and it looked just like a Tamagotchi. And I let it go. And then like 6 months after I finally got to know her, I was like, is your Tamagotchi still alive? She's like,
my
what are you
gosh.
saying? And I was like, what are you saying? And yeah, it turns out it was an insulin pump the whole time. So I felt so stupid. And so for all of you listeners, right? Sometimes they look like Tamagotchis or old MP3 players. Maybe ask the question. Don't be assumptive like me.
At least you didn't try putting a blood pressure cuff on an amputee.
Yeah.
That's a pretty bad one.
You make a mistake once or
Yeah.
twice. All of a sudden,
I
you're a
never
bad
did.
medic.
Moving on.
Sorry.
Type 2 diabetes. So this is going to be insulin resistance typically. So typically we're going to see this in overweight, obese patients. And the way I think of it is if I'm just going to go and drink soda all day and eat candy all day, my blood sugar is going to be so high because there's so much sugar ingested. Eventually, my cells are going to start to, not respond to insulin as well because they're just used to the insulin, right? So they become resistant to that insulin.
So I got a good description for this one. So kind of back to that key analogy, right? So imagine you move into a house, apartment, whatever, and you have a buddy help you move, right? So you do the typical buy them beer and pizza and they help you move, yada, yada. So when you're done, you're like, hey, that was really cool. Thanks for helping me. Here's a key to my place, right? Well, your friend's a little shady and you don't know that. So your friend takes that key, makes a copy, gives 2 keys to his
Who are you
friends.
hanging out with, Wade?
Wouldn't you like to know?
You got to do what you got to do when you're moving.
Right.
Yes.
But so your friend makes 2 keys, they hand it off, and then those friends make 2 keys, and so on, so on, so on. And then eventually you have so many free floating keys that you're going to change your locks, right? So eventually your cells are
That is
no
so
longer
good.
Yeah.
That's good. I like that.
Yeah, your keys are no longer effective. So the same thing with the cell. You have so much insulin, so many free floating keys that eventually your cells say, "Nah, we're closing these gates," and they're not accessible anymore, which is type 2 diabetes.
Yep.
This isn't necessarily diabetes related, but along the same concept, because you have that extra tissue. That's another reason that a lot of these patients have hypertension as well. Your body has to create enough circulation to do that and like to
Accommodate for it.
perfuse those tissues, and so you're getting insulin resistance as well as that side. Like there's a lot of layers to it. Insulin resistance, hypertension, so and they just make each other worse. So it's that extra tissue.
Potentiating problems.
Yep. Yeah, because of this being typically a lifestyle or diet kind of thing, a lot of the time these patients can reverse the type 2 diabetes. If they get into a normal weight, they start to manage their food intake or their diet, they might be able to kind of reverse the effects of this, which is like if you watch The Biggest Loser, that's really common. They'll get off a bunch of medications, including a lot of the time the diabetes medications, because they lose a bunch of weight. Whether the way they do it's not healthy, but in general, if you go and get into a better routine and start to lose weight, a lot of the time you can get off.
So you could potentially walk off diabetes. So you're just walk it off.
Just walk off.
Walk like do you bat flip as you walk off the diabetes?
Yeah.
Like little Freddie Freeman?
Yeah.
Okay.
For surezies. For surezies.
Hold on.
Anyways.
So these patients, they can be on insulin. Sometimes you'll have patients who didn't have that juvenile onset, all of that, but still are so resistant that they will take additional insulin. But typically they're going to be on an oral medication like metformin. Everybody knows metformin now because Ozempic and metformin are essentially they're in like the same family, I believe. I don't think they're the same drug, right? But
they're in the same. Ozempic
or something.
Ozempic is an injectable, I believe, and then
Metformin's
an
oral.
oral hypoglycemic.
Yeah, but they're in the same drug family.
Yeah.
And I want to say people are have been starting to take metformin for obesity as well. So
a lot of people take it for weight loss that don't even have like pre-diabetes or anything like that.
yeah, so you're starting to see that there. So if the name was familiar, it could have been from that. It's starting to be a common thing. But these started as diabetes medications for type 2 diabetics.
Another pill they might take is glipizide. That's another pretty common type 2 medication.
Yeah.
This is going to sound awful, but I heard a quote that made a lot of sense. It was rich people get Ozempic, poor people get body positivity. And I thought that was crazy because I was like, interesting, because it's like, that's not the point of Ozempic, and not to get on like the Ozempic train, but I read that and I was like, I thought this was a diabetic medication. A lot of people are taking it just for weight loss. So they might, if you see those like Ozempic, metformin, glipizide, or anything like that, they might just be on a weight loss journey and not actually be diabetic. So make sure you're checking.
For sure. So typically for these type 2 diabetics, they may have some symptoms, some numbness in the hands or the feet or whatever that's consistent, right? They may have some visual problems. Those are signs of just long-term like hyperglycemia, because we got to remember that sugar is really necrotic to our tissues. And so if we have higher levels in our bloodstream all the time, it's going to affect our tissues because of that. So, and one of the things they're going to be looking for, because we check blood sugar levels, right? And blood sugar range, the blood sugar normal range can vary depending on where you get your information. Right. If you are one of our IMA students, we go off of 80 to 120, and which is national registry standard too. But there are books that might say something different. But
I think some of them go up to like 130 and then 70.
I've heard 70 too. Yeah,
70 is on the lower, and then 130 for the upper.
It's really important to remember that this is symptomatic too. So if any of us were to wake up after being fasted for 12 hours and check our blood sugar, we might be at 68, right? But doesn't mean we're diabetic.
Yeah.
Right.
So it's symptomatic outside of that 80 to 120 range. I always just remember a perfect blood pressure is 120 over 80.
Right.
Just flip those numbers. Easy way to remember that range. And that's going to be milligrams a deciliter.
Yep.
One thing that they're going to look for to diagnose type 2 diabetes is going to be at the patient's A1C range. And so, and again, this is maybe a little bit outside of what you'll have to know at the basic EMT level for testing and everything. But I didn't know what A1C was until I was a paramedic and had to like look it up. So,
I mean,
It's a
I
very
knew what it
practical
was.
piece of knowledge.
I just don't know the numbers. Like I'm bad with lab numbers.
Yeah.
well, it's great that I have that written down
Yeah.
for us, huh?
Hey yo. I know I'm learning.
Yeah, so the A1C is going to be, they're going to find the average of your blood sugars over the last 3 months, and that's going to be the A1C. So below 5.7% is going to be normal. 5.7 to 6.4 is going to be considered pre-diabetes, and 6.5 or above is going to be diabetes. So, if your patients may be like, yeah, I've been doing really well. I have an A1C of 6. Like, cool, you're doing great, right?
Right.
So having an idea of those ranges can really help you have a better understanding of what your patient's telling you. And again, like I said, not test questions, but good to know for the field.
Yeah.
I mean, and also they're supposed to be going and getting it done regularly. They're supposed to be going and getting their metabolic panels, which the A1C is not the total metabolic panel, but like it's a good thing. I get it checked every time I get blood work done because I have non-diabetic hypoglycemia. So when you were talking about that a second ago, it reminded me because I had to do a month-long thing of like checking my blood sugar at repeated or like certain intervals in the morning was one of them because most people are fasting in the morning. And it was interesting seeing how the levels like drop. And I was poking myself probably like 5 or 6 times a day, but my A1C was fine. And so they're like, oh, you just have a fast metabolism, but your A1C is fine. And that's what we care about.
Yeah.
So
Yeah, fun thing if you are in an EMT class in the morning class, come in, fasted, don't eat anything, and then check your blood sugar, and then like bring donuts or something in, something really sugary. One of our old instructors would always do this on this day in his class and just smash his face full of donuts for a little while and eat a couple donuts. Jackson.
Oh, of course.
Yeah, it tracks.
Very on brand for
It
Jackson.
tracks.
It was for the class. That's what it was. Yeah.
Yeah, I mean, dude's in good
He's hot,
shape.
though.
Gotta get
Yeah.
your happiness
Smart
where you
dude,
can
yeah.
get it.
Yeah, he's in doctor school right now, so that's going to be
he is.
He's a
that's
smart
a
man.
future doctor there.
Yeah.
Our
Engineering,
little babies.
engineering degree, and going to be a doctor.
Oh,
He's,
so
he's a smart guy.
It's weird.
But yeah, he would do that, and he would show that spike, and he was normally outside of the normal range on both sides of things.
Yeah.
But it was a good way to show like
Sure.
it can be dependent on other factors. Another thing for blood sugars that where I'm sure we're all really good about teaching, you really need to make sure the finger's clean, because if I just ate a jelly donut and I got some jelly donut on my finger or something, and that could affect readings. So
And wait, just touch the microphone. wait for the alcohol to dry. Do not check a blood sugar if the alcohol has not dried in that area yet. It will, and I've seen it do it, jack up the reading that you get. It will. And don't do like the everyday discouraged from the waving. And so you clean it, you let it dry, and then you check it.
it's like 3 seconds.
It
Just wait.
literally is. Like you see people do it so quickly, and it's like it takes 5 seconds, let it dry. It's not worth getting a skewed number. And I had it happen on a really critical call, and I was like, great. Now they're hypoglycemic too, and it just turned out that the alcohol prep screwed up the reading. So
And then depending on your system too, if you're a basic provider and you're working with an advanced EMT or a paramedic, you understand you can get sugars off the IV sticks.
good point.
Right, that's a very reliable tool. Honestly, like if I could get IV stick sugars, that was my go-to over fingers. There's just so many more moving pieces.
Yeah,
One
for
less
sure.
thing to poke to.
Exactly. So let's talk a little bit about hypoglycemia. So we'll jump into the actual medical issues people can have that are diabetic, that are strictly due to their diabetes, right? So hypoglycemia is pretty straightforward. There's a number of different things that can cause this to happen, right? They took their insulin and forgot to eat something. They exercised more than they normally would have. They were sick and they're burning through more sugars.
They partied.
Yeah, there's
partying, drugs, and alcohol. Like the amount of times I don't know about you guys, but I saw obviously your chronic alcoholics in particular, but like your hyperdynamic drugs, like meth, PCP, cocaine. Like that's gonna drive the sugars down worse, and because of
through it.
and because of how the drug behaves, they're not gonna replenish it because it's a stimulant. So.
Right. Or even one that really burned me one time is post-ictal.
Yep.
Checking them on a seizure patient. I had one patient that it was a learning moment, and I was like, it was a seizure patient. I was like, I'll get a sugar in the rig. Fire guy asked, you want the sugar? I was like, nah, I'll get it in the rig. And then I got wrapped up doing other things, and then finally checked it, and it was low. And it's like, oh my goodness. So now I'm playing the game, trying to get a line, and couldn't get the line. I literally rolled him into the hospital saying, first thing we need to do is give him sugar because his sugar is X. And it's one of those learn from your mistake moments that really bit me, and I'll never forget that.
Yeah.
Well, and those hypoglycemic seizures, I've only seen a couple of those. And when you get to the paramedic level, actually how you treat it, kind of some people feel differently, about how you actually go about it. But I've only seen a couple of those, and they were kind of scary because it was like and the only reason I knew it was a hypoglycemic seizure is because she was a chronic alcoholic that we were picking up off the ground every shift. But we got there and her sugar just read low on the which means it's like lower than like 15 for most.
I think it's normally 20 or 40 dependent on the manufacturer.
Oh, okay. Because I was gonna say the ones where we worked, the lowest one I saw was 6. Then I saw it and I was like, I don't know how it registered that, but hers just said low. And it was all of the things we've been talking about. She had a long history of alcoholism that led into a seizure disorder that led into hypoglycemia, but it was drug and alcohol induced hypoglycemia, and but the seizure was scary. It was really scary.
So that's something that you could see as seizures, right? For these hypoglycemic patients, typically they're going to have altered level of consciousness is really what we're going to look for. So, and that could be a little confused, maybe just a little fatigued and sleepy to like fully unconscious. We might see that. So really any patient that has neurological symptoms should be getting a blood sugar check because it can really mimic a lot of things. It can seizures, it can look like a stroke. They can have a legit full-on stroke symptoms of like one-sided weakness and all of that. And it's just a sugar issue. So we can see that. And then another one that we're going to see a lot is going to be patients that are really cool to the touch and really sweaty or like moist. That's a super common thing. The body just really starts to sweat with no reason, right? They're not overheated. So but they're still sweating and it brings their core temperatures down. So that's something to watch out for.
I heard an interesting little mnemonic, whatever you want to call it, phrase for hyper and hypoglycemic is cold and clammy, they need candy. Hot and dry, their sugar's high. And I was like, oh, that's pretty
good.
I
like that. Yeah, that's reasonable.
Good. Yeah. So you might see, any of those things for these patients. So funny story I have with a hypoglycemic patient that actually really close to here. We went out there and we were on scene for a little while because we got there, we pretty quickly recognized what was going on, started to treat him and everything, but he had been just sweating for a while in a kind of a colder room. So he was like, I want to say he was like 95 on his temperature.
Oh, wow.
He was cold.
Yeah.
And we don't leave patients until they get to like a normal temperature. So we were there for a while. And, I was kind of standing back. It was either my partner's call or one of the firefighter medics was taking it. But they're like doing the IV sugars and just kind of hanging on the back with the fire captain. And we're looking around the house. And it's an elderly couple, right? Like nice golf course, home, elderly couple, right? And there's a bunch of art on the wall. And there's a painting of the patient's wife who's talking to us.
I know exactly where this is going.
Yeah.
I hate this.
Fully nude. And it was a recent painting because she has gray hair.
What?
Right. And so she's,
it's good for them.
Just right there. Yeah.
I support it.
Just right there on the wall. And as we're like kind of like wrapping things up, the fire captain walks over to the wife and's like, I really like your artwork.
Oh, I don't like that.
Thank you.
Oh.
No, it was definitely, it wasn't done in a creepy way. She loved it. It was not done in a creepy way.
No, I know, but I'm sure, especially from a fire captain. Oh, yeah.
Yeah.
It's a smart move.
Oh, for sure.
Oh, yeah.
Yeah, I'll never forget that one. That was fun.
I think so. One of my favorite hypoglycemics, like on the more so of like the weird presentation. It was in South County in a map district that we're all fairly familiar with. And we walk in, and it's a couple older guys, and I was like, "What's going on? Got a diabetes call?" They're like, "Yeah, our roommate I think he's low." It's like, "Well, where is he?" He's like, "Oh, he's in the backyard." And I opened the sliding door, and then there's a dude. I mean, he had to be like mid-60s in his tidy whities, a little overweight, and he is bear crawling around his backyard. And it's like, how long has he been doing that? And they're like, I don't know. It's like, oh, okay. So he's been low, but he got his workout in for the day. We ended up getting his sugar back up, and he's like, why am I so sweaty? It's like, well, fun
You
fact.
were working hard.
Yeah.
You're going to be a little sore tomorrow, man. Good work.
Yeah, so there's all sorts of just kind of wacky, weird, like cognitive
Aggressive
presentations.
behavior.
Yeah,
I've had a couple of those.
Telling you earlier, I had a guy that just kept going like kung fu kick or something like that. And he would kick at us every time we got close. I don't remember how we got sugar into him, but super nice guy once he was.
Yeah.
But he wanted to fight us for sure until that happened. So which happens sometimes.
Yeah.
And then remember too, if you're going to be working on an ambulance, fire engine, police involvement with hypoglycemics can be dicey just because they don't know what's going on, right? And they're defending themselves and doing their job. But I've heard of locally, there was a guy, we were talking about this a little bit, got pit maneuvered by the police where they, hit his car and he rolled his car only to find out he had a sugar of 40. And they were like, oh, sorry, man. Well, you can go. And so not very often do people get pit maneuvered and they're just like sent home.
I was going to say, honestly, that cop was probably like, at least I still got to do a pit maneuver.
Yeah. Oh, yeah.
I saw them I went to the hospital, was at the hospital one time after they did one, and they were like a high school football team that just won homecoming. They're like, nice work, man. And I was like, what the heck is going on? This guy's like, you did a pit maneuver. And I was like, I don't know what that is.
It's like when we RSI for them, essentially.
Yeah,
Like,
exactly.
yeah,
Exactly. I looked at it and I was like, I get it. I'd feel pretty cool if I did a pit maneuver. But anyways, I digress.
Yeah. So cognitive issues, and then skin signs, and then blood sugars are what we're typically going to see for those patients.
Right. One thing that I think would help a lot of early BLS providers, and this was something that I actually stole from one of the former instructors here, was any altered mental status patient, the first two things, stroke assessment, BG. Doesn't matter, just get it. Even if they seem drunk, just rule some stuff out because hypoglycemia is such a mimic. It can throw things off really, really quickly.
Yeah, it's not strictly diabetes, but I remember being told a story in my new hire class for Ada County about a guy that was pulled over as a DUI, taken to the hospital,
Right.
And like they never had him really examined by medics. The Ada County supervisor went, I think, to draw blood to check blood or blood alcohol levels or something, but the next day, his wife came in to check on him or to take him or something, and he was still acting funny. And the wife was like a neuro nurse, apparently, and was like, did a quick exam, is like, he's not drunk, and he had a stroke. That's why he was acting drunk, and he had like lifelong deficits that could have been resolved, but he was sat in a jail cell overnight, so they weren't able to do anything for him. So yeah, if you have any of these, just check a blood sugar, do a quick stroke assessment, rule those things out, and if you're not sure, just go to the hospital.
Takes 30 seconds. Just do your due diligence. Don't miss the easy stuff.
Yeah, those are easy. Okay, so flip side of things for a type 1 diabetic, and this is going to be a little bit different for type 1 versus type 2, but type 1 diabetics, when they're hyperglycemic, are going to go into diabetic ketoacidosis, or DKA. So as they are so starved for the insulin, let me step back. They don't have the insulin to bring the fuel into the cells, so they're so starved essentially because they're not able to get that in, that as the blood sugar rises, they start to produce ketones. So ketones are going to break down fat. It's going to metabolize fat to get some energy out of that, but those ketones are going to affect the pH balance. So they're going to make that patient become acidic as they start to build up. So we're going to typically see that for patients, and really DKA, there's no defined number of what makes a DKA patient because they need to have that ketone production, which we're not going to find in the field. But typically these patients are going to be either high or like 400 plus.
Like 400 or north is what I've read.
And typically most meters are going to read 400 above as high, but typically it's going to be somewhere around there.
Right.
Also, please remember that blood sugar is specific to the person, just like anything else. So their blood sugar might normally be 200, And if they're at 400 and it doesn't seem like they're as bad as maybe they should be, it's probably because they're chronically high. So always asking them if you can, if they're with it or they have family members that can tell you like, where's their sugar normally? That'll not like, and that's why we don't have a scale for it.
Yeah.
You know,
Right.
we
And
just go off
rely
of-
on symptomatic.
Yeah.
Right?
Yeah.
That's
Symptomatic.
Exactly.
Yeah.
So as always, NFP, normal for patient. We need to be thinking about that with these patients. So what we're going to see for these patients, typically earlier signs are going to have some body ache, some fatigue again, because they don't have that fuel, right? The fuel's not able to get in. Nausea, vomiting is common. And then like you were saying, these are going to be really dry patients. So kind of warm, hot to the touch. They're going to be really dry. And then we might see those Kussmaul respirations.
Right.
So Kussmaul respirations are fast and deep consistently. So
Exhausting.
they're typically a regular rhythm, very deep and very fast, and that is just the respiratory system trying to work on the metabolic acidosis that they have from all those ketones. So
Right. It's usually because if you think about the acid that we normally deal with, it's CO2, right? So the brain is like, our pH is so low. Let's just get rid of all this CO2. But it's not a CO2 problem, it's a sugar problem. But the brain can't differentiate in those moments.
yeah, it just knows the brain, the baroreceptor, not baroreceptors, the chemoreceptors recognize the body is acidic, and we fix that by breathing it off, and so it's going to breathe really deep and really fast.
Your kidneys are going to take care of it primarily with your bicarb, carbonic acid cycle and all that. But when it gets overwhelmed, that's why it spills into your respiratory patterns. So because they've reached that state now, they're Kussmauling. But otherwise, your kidneys do a pretty darn good job.
Yeah.
We just
Well,
like
yeah,
jinxed
that
each
was
other, like
really
4 times.
good,
That was
yeah.
pretty good.
You're going to get your sugars,
Yeah.
Get the sugars.
your Coke. Jinx you on your Coke.
I'm going to
So-
watch him. Just say it at the same time now.
Don't blink either.
You might also have patients with that fruity.
Oh,
that
yeah.
fruity
I've never
smelling.
seen that. Have you guys?
Yeah. Yes.
Only a certain amount of people can smell it. So that
Oh,
might
really?
Be it
That
too.
makes me feel a lot
I
better.
had one patient that I was actually going to tube this guy, but we got to the hospital and my FTO was like, "Do you smell that sweet smell?" And I was like, when they talk about it, I was like, "It's juicy fruit,"
Yep,
so I'm
right.
like getting ready. Oh, dude, it smells like that, like fruit flavored vodka vomit, like that. You know what I'm like that really sweet alcohol. I smelled it. I was like, "Oh
Smirnoff whipped.
yeah, that's literally
Gross.
what it smells like. The vomit.
Oh.
Yeah, that's
I
what-
heard old fruit. Someone it described it to me as just like old fruit. Like it's still sweet,
fermenting
but
fruit.
yeah, but like it smells more. I guess acidic was what that would. What they described it as, but
Yeah, like artificially sweet. Because
Yeah.
I've smelled it before, and that's kind of what it made me think of, like artificial sweetener. Kind
yeah,
of like that
I've
kind of stuff.
never smelled it. Maybe I'm just one of them that can't. I also can't eat cilantro, so
Yeah, it's
I'm
a similar
definitely
thing.
definitely a
It's
loser.
probably a good habit though to not have your nose that close to their mouth.
That's
Because I was
true.
close. I mean, I was gonna tube this guy. So
Oh yeah.
live your life treatment wise, but not for me.
Weird. Weird.
Weird? Me?
No, this guy with his face
Oh.
all up in people's business. all the
Yeah,
time.
no.
Sorry, I was gonna RSI. I was about to do my pit maneuver for as a medic. You know.
I almost got spit on one time, and that's when I quit getting close to people's faces.
Yeah. it's a
Well,
good
I've
idea.
almost been spit on a lot of times, but
as anybody has.
it
in
was
this
traumatic
profession.
enough.
Yeah.
Yes.
So for DKA, the late sign is going to be typically unconsciousness or like really significantly depressed neurological symptoms. So
Right.
you might see that ALOC, and then down the line like Foley, GCS3, really out of it.
Wade and I were talking about this before we started. Both, I've tubed a couple of the DKA guys, and in the work, like when you intubate them, you're not just intubating them to take over their airway. And this is a bit more for basics, like EMT basics, but you might see this if you work in a system that has paramedics, and managing their airway is one of the most important things you can do to manage the gases and their overall like metabolic processes. So airway management is almost always a must for these guys, and it's very aggressive and very critical, like confusing.
Yeah. Yeah, these can be pretty complex patients. So for the high side for type 2 diabetics, we're going to have the HHNS. And so that's hyperosmolar hyperglycemic non-ketotic state or syndrome. Thankfully, I had that written down. I always forget what HHNS
I'm used to
stands for.
HHNC.
Me too, yeah.
We probably learned it's just coma.
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 At the end.
Oh,
Yeah,
okay,
hyperosmolar
Because they're
hypoglycemic
so
non-ketonic
altered.
coma.
Yeah, it's the same thing.
Yeah.
Just
Said
different
that
terminology.
fast. Good word.
I know.
Say that 10
It's one of
times.
my favorite things. One of my favorite things to say. I'm good at it.
That's your like supercalifragilistic moment.
yeah. HHNC.
Yeah.
So these patients, they're going to be the insulin resistant patients. And so they're not going to be bringing in that sugar like they should typically. And so the blood sugar is going to start to rise in the blood. So the sugar is going to start to rise in the free floating blood. And then like you were saying earlier, it's going to start to pull water. So that's a common thing when we have these sugar pulls water, right? Which is why like if you do like a low carb diet, you're going to lose 5 pounds right away because you're losing some sugars and that just holds a lot of water. So,
well, and that's what the hyperosmolar means. Part of it is that your serum levels are super concentrated, which is throwing off the osmolarity. And that's what we're talking about with things moving into the cells and the blood vessels and whatnot.
Like more extracellular fluid.
Yes.
Yeah, so all this sugar is free floating. It starts to pull water from all the cells. As this happens, it goes to the kidneys. Kidneys start to excrete it all out. You start to become really diabetic. Sorry, not diabetic. Dehydrated. And you still have all of those other things left in your bloodstream. You still have all the electrolytes and all that stuff still left in your bloodstream in higher concentration levels. So that's what happens for HHNS. So for these patients, you're going to see maybe that polyuria, polydipsia, because they're peeing off so much because they have all this, they're pulling all this water off of their cells and they're peeing it out and they get thirsty because their body's like, I need more water.
Yeah.
I think an important thing to bring in mind with that or keep in mind with HHNS too is remember how many patients you're going to see who have urine bags, right? Like Foley's in all the time.
Oh, yeah.
And that's a huge tool. No one likes looking at a bag of pee. Let's just be transparent. Yeah. But when it comes to like HHNS, you see that dark, really brown color urine and they're kind of not responsive and you check a sugar and it says high. It's like, oh, there we go. Light bulb moment, right? That's a perfect tool. Just keep it in mind. It's not great, but you're going to have patients who have them, especially type 2 diabetics.
Yeah, it's always, I mean, there's definitely patients where you wish you could see the pee. Like, oh, it smells like a UTI. I wish I could see what the pee looks like. Like, check those urine bags. Like, there's some clues in there for sure.
Well, and like, is it urine concentration or is it kidney failure and urine concentration? Because now you're kind of screwing your kidneys over.
Yeah, all that sugar is just going to destroy the kidneys.
It's super hard on your kidneys.
Which is how these patients end up on
dialysis.
Yeah, on dialysis and have renal failure.
Yeah, we kind of touched on it earlier. I just, with the progression, remember that neuropathy happens. So like, don't be shocked either if you have a HHNS or a DKA patient who's not super responsive and they have a gnarly wound.
Yeah.
Would not be surprised. I had one guy, like I literally saw him the day before he was scheduled to have his leg amputated because he was a type 2, didn't take care of himself. And it was one of the gnarliest wounds. The first maggot wound I ever saw in that one. Oh, it wretched me a little bit inside. Yeah, it's a student.
Inside only, I would probably have done it on the outside.
I mean, like, the nice thing is I got to wear a mask for that. So it was like, oh that was nice. Bad. We're going to move on. Sorry, gross. I know I derailed there for a second.
Right.
But I mean, it's if we're talking like diabetic emergencies, that's a big one though. The infections that they get.
Development of sepsis.
Yeah. And then like, I mean, they have so many comorbidities with it. You got to consider heart problems and wound like infections and falling because they can't feel their feet and so there's a lot of layers to these guys that isn't just this, but this is the bulk of what you're gonna you're gonna be dealing with.
Test wise, this is kind of it, but real life, there's a lot more that goes on with these patients.
It's really they're complex. They're super complex.
I wanted to say like an onion, but then it is more like a cake. Because cakes have layers.
Yeah. Okay.
That's a Shrek reference.
I do like the Shrek.
I got the Shrek reference.
Yeah. Spit it out.
Today.
So yeah, you're gonna see that with these patients. So because of the dehydration, they might have some like shock symptoms, right? They may be tachycardic and hypotensive because they're just so dehydrated. So you might see that. And then altered mental status as well. So these patients can look very similar to a DKA patient. There's just no ketone production. That happens for type 1 diabetics, not type 2.
It's because there is insulin. It just doesn't work as well.
Yeah.
And that's why they don't go into ketosis.
Exactly. Yeah. So treatment-wise, these are pretty simple patients, at least at the BLS level.
Yeah.
So BLS level, the only real treatment for these guys, other than recognition and transport to an appropriate facility in a timely manner is going to be oral glucose, which is just a simple, basic monosaccharide, simple sugar that we're going to have the patient eat. It will go through the GI system to bring those blood sugars up.
Yep.
And so this is good for those patients that, I feel like I would always see it a lot around the holidays. Like,
Yes.
you know, I'm holiday shopping and I'm walking more than I normally am through the mall and whatever.
The alcohol consumption that goes up,
yeah,
that's
also
a big
too,
one.
yeah. So these are those patients that, you know, are able to, for me personally, if I can't take that tube and hand it to the patient and say, I need you to eat this,
Right.
I'm not going to give it to him because I'm really nervous about airway obstruction and affecting the airway. But patients are going to be able to take that. And then we don't need to just give oral glucose. Like we've all made lots of sandwiches, lots of
That's what I
orange
was about to
juice.
say. That is the best part of the job. I think one of, well, maybe not the best, but one of my favorite things about working 911 is going through people's pantries and their fridge. Honestly, though,
Judgments. I love it too. I'm nosy.
Yeah.
I get that.
Yeah. I'm kind of judgmental when it comes to some of it because I'll be like, oh, they eat that brand. That's unfortunate. But the reason, or I've actually found a lot of snacks that I want, and then they're like, I'm not gonna eat them obviously, but I'm like, I need to buy that. The other reason I bring this up though is that if you are going to use something else, these people are going to have a lot of sugar-free stuff at their house.
So be aware of that.
Yeah, so like you have to make sure you're checking the sugar content. I think I've probably only had a couple where we actually DoorDashed food one time because they were all drunk and they couldn't drive, but we couldn't leave the kid because he was like not quite enough. So we ended up DoorDashing like juices and stuff for him to eat because they didn't have any food because they were in college.
Right. Alcohol is food.
All they had was Miller Lights.
Yeah.
You know, honestly, it would work, I guess, but you know, you want
Have some other problems.
yeah,
Potentiate.
just use orange juice or whatever. Usually they'll have something like they'll have like 7-Up or orange juice or some kind of soda or drink that has the actual sugar in it, but you need to be doing complex carbs in addition.
Yeah, you touched on it. Monosaccharides, they're going to burn fast. So we need to just get the sandwich going. That's I mean, there's a reason firefighters are good. I mean, they're good at making sandwiches anyway, right? That's like their whole thing. But like
They're good at smoking.
they got to show it off.
Sandwiches are
Smoked
beneath
meat,
them.
chili. Yeah, there's lots of things.
Sandwiches
are
are beneath them.
One thing that I saw with oral glucose one time that, I mean, I've seen it a couple times and I thought it was actually like a good pivot for us is we showed up, you know, hypoglycemic patient, and then we're like, here's the oral glucose tube. I want you to eat this. And he's like, no. And then the wife was like, hey, he has the tablets and he likes those.
Oh,
Check the dude, same exact dose. Yeah, give them to him.
Yeah.
You can buy those at Winco.
Good to know.
Yeah,
they're out there.
I've used them before. They're like, it's kind of like eating Tums, but better flavored, I guess. But yeah, but in a pinch, they're really nice. And I know a ton of people that carry those. I carry them. Like in a pinch, if I just need a little bit of sugar. Ooh, sorry, God, second time today. And then I'll just like, you know, pop one or two of those and it makes me feel better. But I know I have to get a meal.
Yeah. Yeah, that's another good option. And then just real quick, throwing it back to, it's not as common anymore, but insulin stored in the fridge. Now they'll have insulin pens that don't need to be stored in the fridge, but that's always something that's good to look for if you're not sure of a patient. You know, if you just show up at a house and it's just a friend who doesn't know the person very well, you're like, oh, are they diabetic? I don't know. Go check the fridge. There might be some insulin in there. So just something to keep in mind.
Yeah.
That's typically where insulin is stored.
And sorry, this just popped into my mind. Be really careful with people that have pumps because they can get pulled out. And that's not we don't do that. A lot of the times the patients will do them, but that's got a little like feed wire thing. I think it goes into the pancreas, doesn't it? Or something like that? Or is it the GI?
sure.
I don't think so.
It goes somewhere, but it's got that like that's the port for it, and that can get pulled out. So please be careful when you're handling your pump patients because you can rip it out, and it's kind of a pain.
Yeah.
Yeah,
And just,
go ahead. We don't carry and give insulin even as paramedics. That's like a 2-person hospital medication. So we don't do that in the field.
No, just
go ahead.
so just be careful with those. That's all, because if you mess with it, it can give them more.
Yeah. Sorry, I didn't mean to interrupt you guys. Apparently, this is really important for me to say. But oral glucose dose nationally, 15 to 45 grams.
Yeah.
Just to make sure we get it out there.
Yeah, that one's kind of hard sometimes to find on the tubes, exactly how much is in a tube.
Yeah.
Typically, they're going to be 15 for the smaller, 45 for the bigger.
The ones that we had were 37 and a half.
They were.
So just give the whole thing.
Yeah.
I mean,
Just give a tube.
Yeah, that's the go-to. But that's if you're going to be testing, that's the question or the numbers they're looking for. grams
What does
emphasized.
your charting software offer?
Yeah, ours was tubes. So just one tube.
Yep.
Yeah.
Cool. Yeah, I think that about sums it up. For,
I want one more summarization.
Go for it.
So just so for your guys' knowledge, type 1 and type 2 progression. Type 1 sugar production problem progresses to DKA. Type 2 sugar resistance problem progresses to HHNS. Just keep those kind of lines in your head.
Yeah, don't get them twisted.
Yeah, don't get twisted. Yeah.
All right, that's it.
That's it.
We're done.
Cool.
Did you just elbow
That's my
somebody?
that's my gang move.
Oh, that's your gang
got my-
symbol.
my
Oh,
knife.
okay, right on.
Game over.
Hopefully we're on the right camera so people can see your sweet knife.
Sick.
Cool, right on. Yeah. Well, thanks for checking out the podcast. Don't hit it again,
Third time
Kylee.
today.
No,
Third time's
no.
a charm.
Yeah, we appreciate everybody being here, watching the videos, listening on Spotify, Apple Podcasts, wherever you're at. We will see you guys on the next one. Thanks.
Bye.
Bye.